So probably people know me from yesterday. So this is my second talk on chronic fatigue syndrome, which is also called myalgia encephalitis, if it is a, and what we know and what we don't know. And look, everyone talks about chronic fatigue syndrome. At some stage, people would have experienced it. So I'm not going into the in-depth of it, but I'm talking about the current perspective, what is very relevant as of today, and what you can take home message on chronic fatigue syndrome. Of course, the definition is important for us to understand what it is. Needs to have persisted for at least 6 months, post-exertional malaise, unrefreshing sleep, impaired memory and concentration with myofascial pain and polyarthralgia, and sore throat and tender lymph nodes and headaches. So this needs to be present for the diagnosis of chronic fatigue syndrome. And we all know that we have to exclude the secondary medical causes first before we can actually make this as a diagnosis. The cause, probably unclear. It's very complex, but there has been some proposed theoretical aspects in terms of alteration to our immune system involving the adrenal gland and also the thymus, which is pretty much involved in the lymph node. And there are some genetic markers as well and childhood trauma. Invariably, there's quite a significant numbers of childhood trauma associated with chronic fatigue. There is also quite a bit of a blur merging between chronic fatigue and functional neurological disorder. There is also quite a bit of blur between chronic fatigue and post-concussional disorder following mild traumatic brain injury. So there's a bit of a spectrum of disorders. So there's been a criteria which you can use, which is the Oxford criteria for diagnosis. With the primary symptom being fatigue, has more than 6 months, associated with poor sleep, myofascial pain, disturbance in mood, and childhood trauma, and exclude other medical and mental health issues. So this is the criteria. You can look it up on the net from the CDC Control and Prevention. Now, what I'm going to talk about is you can get a lot of information on chronic fatigue. There's a very good information link pathways. In rehab, we talk about, yes, patient needs a lot of exercise. And well, that's the whole point now. What I'll talk about is the PACE trial. So this trial was conducted in UK, and that's actually thrown a lot of controversies in terms of what can be advised for these patients with regards to a rehabilitation perspective. So this was hugely influential with the release of patient data in 2016, showing there's no clinical significant improvement with the graded exercise and cognitive behavioral therapy. But there were some controversies in terms of, so what do you do with this? There has been some new scientific evidence published from the Institute of Medicine report and international consensus criteria on that one. So let's dig deep into the PACE trial, what they did and what can we take from now. So you can talk to your colleagues about what's the evidence-based treatment for chronic fatigue. And I'm also going to propose something else in terms of how we can address the chronic fatigue from a different perspective. So with the PACE trial, what they looked at is the post-exertional malaise was increasingly shown to be one single symptom, and it's not fatigue. So the moment you put the patients into your exercise program, they collapse with the chronic fatigue. So is it the right word? Is fatigue a right word? Sometimes patients say, I'm not tired, but I just can't do it. I won't do it. It's painful. I can't do it. So that's one symptom is considered to be a hallmark for diagnosis. Then the patient survey report consistently showed that the graded exercise therapy and cognitive behavioral therapy treatments were ineffective because they cognitively blocked you off a long time ago. And you can talk about, until the car comes home, but nope, they're not going to engage with you. More than 10 minutes, finished, gone. And you give them 30 to 45 minutes of physical exercise, finished. They've got the overuse weakness already. So not very helpful. So since the NICE guidelines from the European guidelines published all these things in terms of, patients have to be given this exercise program, CBT, DBT, dialectical behavioral therapy, blah, 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 blah. No, nothing worked for these patients. And in fact, if you look at the PACE trial, the number of patients participated in the trial were quite significant. So let's overview on the PACE trial, because that's actually going to influence our future understanding of what chronic fatigue is and how we want to progress with this one. So 641 participants, not bad, yeah, with numbers. Randomization was done by an independent trial unit, and the trial treatment was specified in detailed manual, and it was rigorously monitored, of course. Very little loss of follow-up, which is good. And the main trial analysis conducted by the statistician, which is ideal. And all aspects of the trial were overseen by an MRC-approved independent trial steering committee. So they've sort of fairly done well from a process perspective, from a research perspective. Now, what they found was that the graded exercise program and cognitive behavioral therapy given appropriately as supplements, but not as the core therapy. So what they looked at is the specialist medical advice alone, or you can actually talk about the physical reconditioning exercise alone, or you can actually have a CBT and GET. So what adaptive pacing therapy and specialist alone. You can engage them on spacing therapy, nothing worked. Doctors can talk about them, nothing worked. So what really works for these patients? So to understand that, of course, you can classify the chronic fatigue and myalgia encephalitis into mild, moderate, severe. But the interpretation that has finally sort of the take-home message is the cognitive behavioral therapy and GET will have to be done in a very short 15 minutes. That's it. Has probably a physiotherapist may know about this. Have you heard of the BREAM exercises? Okay. The BREAM exercises are the ones which are given in a very suboptimal but intensive but short burst. That's it. That's called a BREAM exercise. So you actually give, don't ask me why that name is, but it is there. It's a suboptimal, say about 60 to 70% of your total max exercise, VO2 max. Give them in a short burst, 15 minutes max, that's it. Don't give them more than that. Similarly, with the CBT, have a 10 minutes of CBT, that's it. Don't talk to them lectures, nothing works for them. Why? Because with the myalgia encephalitis is that they go into this, what's called as a cognitive overload. So why people get this is because, which I'll go to the biochemical and also the pathophysiology of it. And some of them with the childhood trauma, why they are more prone to dissociate themselves with that trauma has gone into this somatic aspect of the medical aspect of this condition. So any cognitive overloading, they shut the brain. And it can be a very short, intensive input, either visual, auditory, or a physical input or a sensory input, they shut down. And that you can understand similar to a functional neurological disorder. If there is an overload happens, they tend to interpret into the physiological forms, which can be form of pseudo seizures. They can have tremors, and they can have a functional gait disorder, and they can have a sensory impairment, perceived sensory impairment. All of this, the brain actually perceives. Why they get it, we don't know. That's a functional neurological disorder. But the cause has been due to the cognitive overload and stimulus overload. And it is variable from patients to patients. So The outcomes with the specialist medical assessment alone or activity-based treatment can be a supplement. So when these patients come, the recommendations are that you identify the grade of their CFS, you talk your allied health team in terms of based on the PACE trial recommendations. You have to give them a very short BREAM exercise program. Similarly, with the CBT, get them going as an ambulatory outpatient based. Do not admit them as an inpatient. Preferably, everything has to be done through outpatient based. Inpatient is a disaster if you admit them, because it's not going to go well. So I'm actually recommending to my colleagues is that if you see patients in the CFS in the clinic, don't reinstate or what's the right word? Reinstate their disability. So make it very quick. Whatever you talk, the consultation, make it very quick, explain to them, and refer them to the outpatient-based rehab. But after having gone through these PACE guidelines, I'm changing the way I'm dealing with these patients myself. Because previously I used to think that educating them on graded exercise, you need to do physiotherapy. That's preaching. That doesn't work. It's like telling a person to quit smoking. For myalgia, encephalitis, it doesn't work based on these recommendations, of course. This recommendations is not without controversies again. I mean, it's not going to be universally followed, but I thought it's not a bad option. But then I went to the other aspect of the chronic fatigue, because I was also interested in photobiomodulation therapy, which I actually asked one of the colleague, Jay Spector, about that in terms of the medial stress, because photobiomodulation is your near infrared light therapy. Now, yes, there's a lot of controversies about it, but it's got some reasonably good evidence now that light therapy is actually good. Now, why? Why light therapy is good? Now, the infrared light therapy with wavelength of 600 nanometer to 1200 nanometer seems to have a very good in-depth penetration into our body. What does it do? So in the animal models, it's been shown that it actually activates the reactive oxygen species. Now, where is the ROS located? Mitochondria. So it activates the mitochondria with the ATP and the reactive oxygen species. Only the infrared light can do that. That's it. And that's probably the reason why we are recommended to go into the sunlight and have light therapy 20 minutes every day. Because you feel energetic when you go in the sun. Because your reactive oxygen species gets activated in your mitochondria. People with chronic fatigue syndrome, they are absolutely isolating themselves inside their house, never go out. Ask them what their lifestyle is. So essentially, your light therapy, the photobiomodulation, has got some good, reasonable evidence now to promote this. That made me look into what the ATP profile testing can be done for these patients. So you know that the ATP profile that yields about 5 independent numerical factor from 3 series of measurements that can be done. So you take the blood tests, 3 samples of blood test, and the concentration in the neutrophils are measured in the presence of excess magnesium, which is needed for the ATP reactions. So this gives the factor ATP units in nanomoles per million cells. So it actually finds out the amount of magnesium that is trapped between these cells in the neutrophils, and the ratio is calculated. Based on that, there's quite a bit of an article on this one. It indicates the mitochondrial dysfunction of the neutrophils in the patients in the cohort, and moreover, the degree of dysfunction is strongly correlated with the severity of illness. So this is the new finding that has come up with the chronic fatigue syndrome, because we all tell these patients that it's all in your head. It's all in your head. You've got to be psychologically moving on. You know what? It's nothing wrong with you. All the scans are normal, because this is a biological disease or illness. And patients are pretty much prone, based on their biological markers, their childhood experiences, their trauma, and their dissociative personalities, because the trauma will result in you wanting to dissociate with any future trauma that can be in the form of even exercise. can be in the form of preaching, can be in the form of any cognitive overload. So if they perceive that a threat as you telling them what to do, which will cause pain, that's a trauma. It'll go back to the limbic system to do the same thing, shut down. So this ATP profiling was an interesting new clinical test that has come for chronic fibromyalgia. And this actually looks at the mitochondrial dysfunction. And I have bought the device, the photo biomodulation. So hopefully I'm hoping to talk about this in the next, because I need to have some data to even talk about it. But there is a theoretical aspect of it. So I want to find out whether the photo biomodulation using the transcranial, because we have a transcranial photo biomodulation, helps with these patients with the central dysfunction, with the fatigue. Because for these patients, I tend to use, what I tend to use is palmitoyl ethanolamide. Is anyone aware of the palmitoyl ethanolamide? It's a medication called PEA. Has anyone heard of that? It's a herbal extract. So it actually works on the microglial cells in your body, and it actually promotes energy by activating the mitochondria. So it's called PEA. So use 300 milligrams, one capsule twice daily, and it is off-label prescription. It's a private script. So I tend to use them instead of using them on opioids or anything else. That actually helps. The second medication I tend to use is thiamine, multivitamin B1. People laughed at it when I actually said this. Even my colleagues actually said, oh, for chronic fatigue, they come up with these opioids. They have this Targen and prescription. I did all the opioid tapering. And I actually gave them this thiamine. And then I said, what's the rationale? I said, you go and look it up. I'm not going to tell you. So what thiamine does, is the B1 does, is the Krebs cycle. You have to go back to your basic medical school biochemistry. So Krebs cycle, you need multivitamin B1 NADP for the production of in the Krebs cycle for the energy production for the ATP. So these guys are already running very low on the mitochondrial ATP. So you need to have the thiamine 100 milligrams 3 times a day, not just once. And that helps with the energy production. Third medication I use is amantadine. People said, why? Well, again, amantadine has got the neuroprotective effect, and it's used for dopaminergic preservative. So patients with very early onset Parkinson's disease, you can use amantadine. But then all these newer formulations of medications has come into place, and they push amantadine away. And in fact, amantadine is actually a short supply in the world, in Australia especially, at least. So we can get it. So amantadine helps with two. It is an antiviral, we all know that. And B, it actually protects, it offers a neuroprotective effect for your subcortical structures, especially substantia nigra and dopamine producing agents. Thirdly, it also works at the your pain, the thalamic structure. So it's actually very good for central sensitization pain. So patients with central sensitization of pain, I tend to use amantadine. So for these group, I have used thiamine, amantadine, and along with that, you can actually give, but I'm looking at the photobiomodulation. I've just bought the device from Symbix. No conflict. I just have to buy it. I just wanted to have some data in the future before I can talk about it, because right now my position is I do not know whether it works. But maybe in the future, I don't know. I can actually come up with the data to say whether it works or it doesn't work. But at least I want to trial it, at least in my clinic. So the way that the individual factors in the mitochondrial energy score can also be produced, patients are affected in the same way. So this is just the theory of it. So the recommendations from a chronic fatigue syndrome, in principle, is graded exercise and cognitive behavioral therapy in a short burst, along with the medications which I've talked about. It's worthwhile that you guys go back. Whoever is interested in chronic fatigue syndrome can explore that medication option. What does thiamine does? And in fact, there's another note that thiamine that comes in because you all know that thiamine is a water-soluble vitamin, right? It's a water-soluble, which means it's not fat-soluble. All your fat-soluble vitamins will get stored in your body. Thiamine never gets stored in your body. So you need to replenish it every day because it's water-soluble. It gets sort of dissolves in the water, and then it actually goes. So you need to. So fortunately, most of our vegetables, more of the diet that we eat has got thiamine in it. Of course, greens, a lot of greens, but so you need to replenish them. You need to take them on a daily basis. So thiamine is one. You can actually PEA is another option. Again, you can look into the palmitoyl ethanolamide. If anyone wants to look up further, there is some evidence. I can't say it is a great, because in my clinical experience, PEA is a hit and miss. But I'm not harming the patient, because essentially there's no significant side effects associated with it. But at least if I can use the PEA and use the placebo effect and cut back the opioids, I've won it. That's it. I don't care. It doesn't matter. But at least I can use that placebo effect to cut back the opioids, because there's a huge opioid thing going on with this chronic fatigue syndrome. And then I tell them to go in the sunlight. Just go out, you know. But now, instead of preaching, I think we need to have a standardized therapeutic exercise prescription, which that's my take on this PACE trial, is that to provide a therapeutic prescription to my allied health clinicians, this is what the patient needs, plus the medication option is what I'm going to do. And then future, what I'm looking for is to see if the transcranial photobiomodulation, as it states in theory, is helpful for these patients and minimizes their dysfunction. So that's what I've got to say about chronic fatigue and myalgia today. Questions?